Welcome, everybody. Good morning. Thank you for joining us for this Pathway Partnership Programme Showcase event. Over the next hour, we're hoping to tell you all about the Pathway Partnership Programme, how we can work with you to improve outcomes for your inclusion health population. We've chosen you, we've contacted you because either we've worked with you in the past and there may be work that we can pick up and work with you again, or because we think you're interested in an area that could benefit from working with the Pathway Partnership Programme. So my name is Dr. Chris Sargent. I'm the Medical Director of Pathway and the Clinical Lead for the Pathway Partnership Programme. If you could please add your name and organisation and job into the chat, that would be really helpful. We have all your email addresses, but we don't necessarily know how that relates to the work that you do. If you could please keep yourself on mute, that helps the presenters because otherwise they're being interrupted during the presentations. Towards the end, we should have some time for questions. If you want to ask questions as we go along, that's fine too. So there's a Q&A function in the taskbar at the top of the screen there that you can use to put questions in. We'll try and pick those up either from there or from the chat as we go along. We're recording this meeting, so if you don't want to be seen, do keep your camera off. So yeah, just to warn you that the recording's happening. So what are we doing this morning? So we're going to talk a little bit about what the problem is that we're trying to solve with you. We're going to talk about how the Pathway Partnership Programme can help with that. We're going to hear initially from Gareth Murphy, who's one of our lived experience group, who is currently moving from Hull to Leeds. So we're lucky to have him today because he's a busy man. We're going to hear from me a little bit about what the issues are around inclusion health, homelessness and health. How can we help? We're going to hear from Paul Hamlin, who's our Pathway Partnership Programme manager, about what the Pathway Partnership Programme does. We're going to hear from Sophie Kerner, who's our lead in mental health and lived experience, about how we support teams in localities. We're going to hear from Theo Jackson, who's our lead for research and data, about some of the outcomes from the teams. Then we've been joined by Steve Cox, who's a commissioner from Devon, who's going to talk about what it's like working alongside the Pathway Partnership Programme, sort of on the ground in reality. And then we'll have time for some questions and wrap up at the end. So we'll move on to our first presentation, which is from Gareth from the Lived Experience Group. Over to you, Gareth.
Hi everybody, good morning and thank you for joining us this morning. I'm just going to give a bit of a discussion about my past, and I now work alongside the Pathways Inclusion Health team and the work they do and how important it is. The Pathways Inclusion Health team is nothing short of a lifeline for people experiencing homelessness. In 2016 and 2017, I found myself repeatedly admitted to hospital due to alcohol and drug overdoses. My turning point wasn't a clinical intervention. It was a moment of compassion. A doctor spoke to me without judgment. A member of staff treated me with dignity. That simple act of kindness marked the beginning of my recovery journey, one that has since led me to working in a hospital, now supporting others. Yet stigma still persists, particularly towards individuals with substance use disorders, and even more so when they are homeless. Many of those living on the streets carry histories of trauma that most people could not begin to imagine. They arrive at hospital needing care, compassion, and understanding. Too often, they are met with suspicion or disregard. We speak often about trauma-informed care, yet it remains worryingly absent in clinical practice. At Hull Royal Infirmary, where I currently work, the homeless health team is doing essential transformative work. They ensure that some of the most vulnerable individuals in our society receive not only medical treatment, but also the respect, dignity, and empathy every human being deserves. For many, this team represents the only constant support or kindness they've experienced in months or maybe even years. In 2017, when that doctor showed me kindness, it changed my life. I cannot begin to estimate the cost of my repeated hospital visits to the NHS, but I can say this: I needed that care. Before my life unravelled, I had worked and paid into the system like anyone else. When things fell apart, I did not need judgment, I needed support. The work of the Homeless Health Team goes far beyond clinical care. They create a safe space for people to begin healing. Every member of this team embodies a powerful blend of professionalism and humanity. Their values shape the team itself. Those who do not embody them, they do not stay long in the Homeless Health Team. It is through this model that Pathways Inclusion Health continues to attract the most compassionate and capable individuals. I could speak at length about the cost savings their work generates, from reduced bed days to fewer emergency department visits. Through effective collaboration with housing services, amongst others, such as working alongside my organisation that works in drug and alcohol rehabilitation, I could share how they help people who've been deeply traumatised learn to trust again. But the most important thing I want people to understand is this, that compassion saves lives. This is not to say that people in the NHS do not show this, but the NHS staff work incredibly hard under immense pressure, but many just aren't trained to see the person behind complex unmet needs. They are trained to treat the disease or the illness, to patch someone up and then send them on their way. This is why the homeless health teams are essential. They do not just see illness, they see the individual. Last night I was sat watching the film Big George Foreman. Whilst everyone else saw George as an angry young man with no hope, Doc Broadhouse saw George just needed support, care and help. Watching Doc on film was like seeing the homeless health team in action every day, seeing the person behind the trauma, behind what has come before, and how if we give people hope and care, they can become greater than anything they've ever imagined. Nobody in this world has ever achieved greatness alone. I am living proof at what can happen when somebody is simply shown a little humanity. If the homeless health team had been present during my time of crisis, would I have cycled in and out of hospital as frequently? Would I have occupied so many bed days or consumed so many emergency resources? I will never know for sure, but I do know this, it took 2 years before someone was kind to me, and that act of kindness saved my life. And that is why I now volunteer with the Homeless Health Team, because the work that they do, it just covers so much, and it's just so important to people who are homeless, who don't receive a lot of care. Just treat people like human beings. And I know a lot of people sat hearing this now will probably think that happens every day. Sadly, it does not. We all know stigma persists in society. A hospital is a microcosm of society, so sadly, it's still acceptable for people to be spoken about derogatory if they are homeless or if they are under substance use disorders. And for that reason, this is why I'm here today, just to share a bit about my story. I'll pass you back now to Chris.
Brilliant, thank you, Gareth. I think it's always very important to remember lived experience, and that's why we're all here, because we're trying to make things better for the people who are using our services and make changes to their lives. A couple of people have said they can't access the chat, so they put comments in the Q&A. I don't know if anybody can do something about that in the background while I go into my bit. So as I say, my name is Dr. Chris Sargent. I'm Medical Director at Pathway. So I'm going to talk a little bit about Pathway in general and what are the issues that we see and what we're trying to help you make progress with and solve some of those problems. So Pathway's a unique national charity. Our aim is to improve the health outcomes for people experiencing homelessness and people in the other inclusion health groups. We do that in a number of ways, particularly by creating and supporting specialist Pathway hospital teams, so in-reach teams in hospitals that go and find, support and plan the discharge for people experiencing homelessness when they're in hospital, and you hear more about that later in this presentation. We promote the lived experience voice because we believe that we should be listening to the people who use the services about how to best deliver them. We gather data and do regular reporting, so we produce a barometer report every year about homelessness and health and how things are going in that world in general. And we also produce an annual report about our Pathway Partnership Programme, collating the data from all of the teams to show, again, what's happening on the ground. And Thea will go through some of those results a bit later. And we also try to influence at all levels of both the health and the political system, right from going to Parliament to talk to parliamentary groups, down to individual levels, individual hospitals, individual trusts, trying to help them improve their performance in this area and to help more people in an appropriate way. Thanks, Paul. So why are we doing this? What are we trying to actually achieve overall? So we're trying to reduce those extreme health inequalities, health inequities that face the inclusion health populations. And for people who don't know, that's people experiencing homelessness, people who sell sex, vulnerable migrants, and people in the Gypsy Roma traveller groups. So how we do that? First of all, by collaboration. So we believe in working alongside people, trying to help people improve. So maximizing the benefit of the services that are already there. We'll often go to an area and find that there are people working in services, very closely related services, sometimes working with the same people who don't know about each other, don't know each other personally. There's a lot that can be done by bringing people together and finding the synergy from the different organizations. We want to provide accessible and appropriate and trusted services. It's all very well to have a service that people either don't know about or can't access, or is there at the wrong time in the wrong place. They've got to be right for people. They've got to have the right range of people and the right range of services available, and they've got to be trusted by the populations that we're expecting to use them. If people don't trust services, they won't go there. If they go once and they're turned away, they won't go back, and they'll tell all their friends not to go there either. So it's important that services build trust within the communities that they're trying to serve. Where there are gaps, we like to try and help fill those in. So we can help advise on what's the next step. If you've got a good primary care service, what's the next thing to add on to that? If you've got a step down service, how would you ensure that the links into the hospital are working properly? We want to work across those gaps, both between services and budgets, but also people. It helps if people are working in different parts of the service, because then they see the problem from both sides and come up with the best solution. So a lot of the people who work in our pathway teams will also be working in community services too. They'll be following people through different services around the hospital and back out again when they're discharged. So it really helps the patients to feel that somebody knows them really well if they've seen them in all those different situations. We believe in this is part of the lived experience input, co-designing services, the people who use them, and also co-designing research when we're looking at what's needed in an area, to include the lived experience group there right from the beginning. And ultimately, and probably the thing that lots of people here are interested in, is reducing the need for hospital admission and hospital readmission. We find that people commonly are admitted to hospital, treated, but then they're discharged back out to the same situation that they came in from. And that might be living on the street, or living in very unsuitable accommodation, or living in an unsafe situation. And if you put people back into the situation they became unwell in the first place, they're very likely to come back into hospital again. If people discharge too soon, or people discharge themselves from hospital because they're not feeling they're being well treated, they're much more likely to come back again, possibly in a worse state, possibly from an episode of care that's going to take longer and cost more. So we like to see an admission to hospital as an opportunity to change things, to really get in around a person, bring the services in from the outside, and make a difference to when that person's discharged, so that life can move on in a different direction following a hospital admission. So what does all this result in? So very poor outcomes, as you probably know, for people in the inclusion health group. So standardized mortality ratios, or death rates, 10 times that of the general population, and much higher than even people in the worst housing situation, or the most deprived areas. And that's a result of premature frailty. It results in early death. There's a link also into adverse childhood experiences. So people with multiple adverse childhood experiences are much more likely to experience homelessness later in life and find it much more difficult to thrive. We've mentioned repeat admissions and attendances. We find that discharge to assess, where people are assessed once they're discharged from hospital, obviously doesn't work well for this population. But where should people be assessed? Where are the intermediate care beds? Where are the step-down beds for people where they can go for a bit of extra recovery time? We find that duty to refer doesn't work well for this group in lots of places. Staff are not aware of the need to refer people to their local authority and how that can kickstart some action around housing. We find that guidance in this area is often not followed. So we have good, very good, nice guidance that was released a couple of years ago. We've got discharge guidance, we've got an inclusion health framework, but progress with those is slow or non-existent. So we really need to get people to be using the guidance that's there. There's often poor joint working across services, so particularly between secondary care and primary care. People in primary care may not know that their patients have gone into hospital. They may only know what's happened once the person comes out again. So pathway teams can really help to improve that communication while people are in hospital. The evidence-based interventions that we do have, like pathway teams and intermediate care step down, there's not enough of them. They're not spread enough. And we need more investment into those areas to improve outcomes. We find that staff, particularly in hospitals, are not well trained or aware of the areas that are needed for the inclusion health groups. So treatment of opiate withdrawal and alcohol withdrawal is often not optimal. Find that treatment of mental illnesses is not great in the physical health setting and vice versa. So this can result in high levels of self-discharge or people being discharged back out to the street again before their treatment's complete. And so this all adds up to a picture of staff sort of wanting to help, but not knowing how to help, not having the resources, not having the support, feeling overwhelmed. And overall, we know that there are over 4,000 people are discharged out from hospital back out to being homeless again every year. It's probably double that number because only half of the trusts responded to the freedom of information request that was put in. So that we're looking at something like between 11 and 22 people per day being discharged back out to the street. And each one of those discharges is a missed opportunity to intervene and make a difference to that person's life. I think I'm going to hand over to Paul now.
Thanks, Chris. Hi, everyone. I'm Paul Hamlin. I'm project manager for our partnership programme. So how can Pathway help you? So we've got 3 options in our partnership programme: homeless health needs assessments, our bespoke consultancy work, and support we can provide to set up and run Pathway hospital teams, which we're going to go into in a bit more detail later. So I'll just start with needs assessments. So needs assessments have previously been commissioned by ICBs and NHS trusts to help them understand the health needs of people experiencing homelessness and other inclusion health groups in their area, to identify gaps in service provision, including how hospitals care for and support discharges of people experiencing homelessness. We usually make recommendations for improvements to services, and we can also forecast potential health and cost improvements if a pathway team or other service changes are implemented. Our consultancy work is a bit more open-ended, so commissioners and system leaders, you can tell us your needs and we'll develop a bespoke offer of support for your area. So a needs assessment might not be needed if you've done some scoping and are aware of some of the local gaps and issues already. Our consultancy work is collaborative, so we're happy to partner with local experts and organisations to deliver the outcomes that you're interested in. And the third service we offer is support through our partnership programme with the scoping, implementation and ongoing operations of homeless hospital teams, which we call pathway teams. So in a moment, Sophie's going to tell you a bit about how we support these teams, but before that, I'll give you a quick overview of the service model. So what are pathway teams? Pathway teams are hospital-based, they're multidisciplinary, and they're clinically led. So they've got nurses, GPs, OTs, and other specialists. We've also got housing and care navigators. Often the care navigators have got lived experience of homelessness. And the teams also draw on other expertise. For example, some have access to legal advice around housing and immigration cases for their patients. And what they do, in summary, is to find, support, clinically advocate for, and also plan safe discharges for people who are experiencing homelessness in hospital, with an overarching objective of improving health outcomes. So this work is varied and often complex. And how is it delivered? So it's through holistic health assessments and clinical advocacy, so ensuring people aren't just treated for the condition they're admitted for, but looking at their other needs and making sure these are addressed during the window of an admission. The teams often host multidisciplinary team planning meetings so to coordinate plans for patients. So they will involve a whole range of hospital teams and other services, both within the hospital and the community. They'll also do a lot of training and advising hospital staff on homelessness and inclusion health. And with the patients, they'll be linking them into substance misuse services, mental health, primary care, domestic violence services, and many other services besides. They'll also carry out the hospital's duty to refer duties in most cases and support staff to do that when they're not available. And they'll also support patients through homelessness applications and also look at any and all other possible routes into safe and appropriate accommodation. So now, while the model is hospital-based, there are some local innovations on this core service. For example, some of the teams have got capacity to do outreach in the community, so doing a lot of work around admission prevention and working with high-intensity users. And several have also got step-down and intermediate care services for people leaving hospital to support them when they leave. So who's a typical pathway patient? Inclusion health groups have got high rates of physical and mental health problems and often substance misuse issues. Our patients face stigma and systematic exclusion from services, and they often have complex social and support needs on top of their health and care needs. This complexity can't really be successfully resolved without multidisciplinary input, and without a pathway team, there's often a lack of coordination around all these different issues. The other thing I could mention here is that homelessness covers a whole range of situations. So as well as rough sleepers, pathway teams will see sofa surfers. They might see people fleeing violence, whether domestic or gang violence or other violence, and therefore they're homeless as a result. They do a lot of work with vulnerable people who have been cuckooed, that had their tenancies hijacked by other people, people living in hostels and temporary accommodation, and people in a whole variety of inappropriate, precarious and other dangerous housing situations. In some areas, especially in London, we've got a high number of people with immigration issues, and they often need legal input before they can resolve their housing, their care and their support long term. So some of the barriers that patients face are not being able to access a GP. Often administrative requirement for ID and proofs of address mean that our patients can't access GP prior to coming to hospital. There's a lot of digital exclusion, language barriers, communication difficulties, could be around cognition or mental capacity, but also around trauma. Often services are inflexible and not appropriate for our patients' needs, so times and locations may not be suitable for their lifestyles. And often our patients experience logistical difficulties engaging with health services. It could be travel costs, having to leave their belongings on the street or having somewhere for their pets to stay, and also substance dependency and the fear of withdrawing if they do come in for treatment. So where are we currently working? So we're currently supporting a network of 18 teams. Our partnership program has been going for 6 years now, and we currently support 5 teams under this program, but we were supporting 9 teams until very recently. We also provide a lower level of support to the whole wider network of legacy teams that preceded the program and some of the previous partnership teams that are still operating. Lastly, here we've got blue dots where we've been engaged by commissioners on a consultancy basis, or we've completed needs assessments for them. And now I'll hand over to Sophie to talk about the support that we provide directly to the partnership teams.
Hi, I'm Sophie. I'm a mental health lead and also lived experience lead as well. So I'm going to just talk about the different kind of types of support that we offer. So the first one is mainly at commissioners and service providers, and that's thinking about building a case. So we know that early engagement with the right stakeholders is really important, and that's across health, housing, social care and the voluntary sector, and really important to bring in the lived experience engagement very early on. And we know that by doing that early engagement, it can ensure that there's smoother commissioning process and also more active involvement from senior clinicians and commissioners throughout the process. And then there's better communication between the hospital, community and housing, which has better outcomes for patients. As Paul's already mentioned, we can provide support around needs assessment. And this is another opportunity to engage and work with local stakeholders and give them an opportunity to talk about the local inclusion health landscape and to bring that all together. And again, it's really important to think about the lived experience voice within those needs assessments, and we provide support around engagement either locally with organisations or accessing our lived experience group members to come and help with interviews and some of those sorts of activities. And then there's support around building a business case. So we can share our experience about developing business cases. We've got up-to-date evidence that can be used around developing a service and a team. We can support around costings and how a local service may look, because it can be slightly based on a needs assessment, and it can be slightly different in each area. And then moving on to service design. So if a business case has been successful, we can help with thinking about the service spec and the design of the team. So we can bring our experience around kind of the budget, how the service will operate, the monitoring and reporting of the data from the team, and also clinical governance, and also thinking about how the team will be managed and fit within the organisation where it's hosted. We then can support around partnership agreements, and this is usually between us as Pathway, the hospital trust and local commissioners, but may be with other organisations as well. And part of the agreement is agreeing kind of roles and responsibilities of each of the different organisations involved. And we found it's really important to establish that early on to avoid confusion, but also to make sure that the service is set up appropriately. Next slide, please, Paul. So the next phase that we can provide support is around implementation of the service. So this is really actually once it's kind of the service set up. So team recruitment, we have a number of different job descriptions that we've developed over the years, and they're usually matched with the bandings in the NHS. We've got interview questions that we can help provide. And then our experienced clinicians can also be part of interview panels and can support lived experience involvement in the recruitment process as well. And that's often just, there may not be anyone locally who has that who has either lived experience of homelessness, who's involved with services, or it could be that actually there aren't people in the interview panels who have the inclusion health experience. So that can be quite helpful. We also support around a comm strategy, and particularly around a team launch event, because we found that bringing everybody together, all those stakeholders and anyone who might be in the hospital, raising awareness is really important for the success of a team. Also, we provide practical advice and support around the setup, and this can vary from kind of finding an appropriate office space to honorary contracts if you've got people working who are recruited from different organisations, and having access to the right local IT systems, which actually can be quite a challenge for teams to set up and not be able to write notes in the hospital clinical notes, or to share those across services. And obviously that involves also information governance as well, and supporting around that. We also can support access around the hospital charity funds for things like clothing and those dignity funds and things, and phones for patients, because those are all really important things to have thought about at this stage, so that they're there for the patients, so that the service can start that compassionate service right from the start that Gareth talked about before. And then with baseline data, it's really important to kind of have that. And then we can support around involving local information governance and IT teams around what the ongoing data collection process will be and how that can work for the team. And then we offer a 2-day induction, which recognises that team members may have come from a broad range of experiences and may not have either worked in inclusion health, or may have worked in inclusion health but not in a hospital setting. So part of our induction is about building a team together, making sure that that knowledge is shared between the team, and that everybody has a kind of a baseline level of values as well. Paul, next slide, please. And then once the team is up and running, we offer direct support to the team, and this the main form of this is in our structured monthly calls, which often initially are much more around the kind of practicalities of being a new service and setting up, and recognizing that it can be quite a tough service to kind of work in. You're often having to challenge stigma and working within quite established but inflexible systems. So that can be a real challenge. So we can support the teams with managing some of that. And then we also can support them around setting up an inclusion health MDT meeting, which helps the team to develop and maintain those relationships with other people who will be working with the same client group, and ensuring that the individual clients have their needs addressed in a really holistic and coordinated way. And then once a team is more established, the meetings are much more kind of focused around the challenges, quality improvement, development, and kind of things around safeguarding. We also have an annual visit, which is really about maintaining our relationship with the team and to see what's happening locally, and support around QI, quality improvement developments. And I think we'll kind of move on to then talking about the national network. So we have a national network, so we offer monthly master classes, which are on a range of subjects. So recently we've had some on autism and homelessness, clinical advocacy, trauma-informed communication, and brain injury, just to name a few, but they're on kind of requested themes from the teams. So we listen to our network, and bringing the teams together across our network gives an opportunity for that shared experience, but also opportunity to shadow other roles within other teams as well, which strengthens that knowledge base, and having access to profession-specific roles as well, networks as well. And we found that the power of that network is really important for making change across the system as well. And then just lastly, based on kind of our experience, we found that having reflective practice is a really important part of it. And as Paul's already mentioned, that legal advice, particularly around immigration, but it could be around housing or care, and we can support setting up those relationships, but often it's dependent on local funding for those parts of the service. And all of that is supported by our multidisciplinary team, which we hope reflects the teams that are set up as well. And I'm going to hand over to Theo now. He's going to talk a little bit more about the data and outcomes.
Thank you, Sophie. Morning, everyone. My name's Theo Jackson. I'm Pathways Research and Data Lead. So I'm going to talk to you about some of the key data points and outcomes that we've seen across the programme from the past year. Just before we start looking at the data, as Sophie has alluded to, we provide a range of support to our teams to actually enable them to collect good quality data, to evaluate their impact, and show what they're doing for patients and also for the hospital systems that they're working in. So just a quick overview of the kind of things that we do in that space. Firstly, we have a quality monitoring data framework which has been developed based on our expertise of working in the inclusion health space. So it's a data framework that not only allows the teams to show their impact, but also has several key quality indicators that allow the team to keep track of their activities and drive quality improvement processes locally. So to enable data collection, we do a lot of work with local IT and business intelligence teams, helping to set up data collection templates and forms, for example, within clinical systems, to make that as easy as possible for teams. We also conduct data analysis and reporting across the whole of the programme. We produce annual evaluation reports, which go into a little bit more detail as well. We provide teams with a range of materials to collect case studies, which are really important for showing that patient journey, and also to collect patient feedback as well, which is a really fundamental part of quality improvement and actually showing the kind of human impact that the teams can have. And then we also provide support for teams and commissioners around economic and return on investment analysis as well. Next slide, please. So starting off to look at some of the data we've collected from the teams. Firstly, just looking at the number of patients that have been supported by the programme over the past year. You can see there that in 2023-24, our teams worked with 3,377 individual patients, works out as an average of 422 patients per year. So there's obviously a really high level of need for these services where they're being set up. They're identifying a lot of patients that need that holistic support. And as you can see on the chart on the left-hand side, over the 2 years, you can see an increase in the number of patients that our teams have been working with. Obviously, we all know the context. The numbers of people experiencing homelessness continue to increase. The demand and the need for these kinds of specialist services continues to increase as well. More and more people experiencing homelessness and in other inclusion health groups are going to be coming into hospital, and we need to have effective responses in place. The chart on the right is showing some of the very Thank you. Chart on the right is showing some very high-level patient needs that we've collected from across the team. So as Paul talked about, pathway patients typically very complex needs, really needing that holistic and multidisciplinary support. So what we found from 23-24, over 60% had substance misuse needs, over 60% mental health needs, 40% had dual diagnosis, so that's both substance misuse and mental health, and around 40% also had safeguarding concerns as well. So that really just to show the complexity of the patients our teams are working with and the real need to have these specialist services in place to effectively meet their needs. Next slide, please, Paul. So one of the key outcomes that we look at is the impact that teams have on the housing status of patients. So as my colleagues have described, pathway teams conduct a range of clinically led housing advocacy, and the clinically led part is really important because it's not just enough to send off a housing referral, you need to support that with some very concrete clinical evidence as well. So some of the key data points that we found in relation to housing from 23-24, 89% of all consenting patients received some form of housing advocacy, whether that was the statutory duty to refer or an alternative form of housing advocacy. And the duty to refer point is really important because, as Chris said, a lot of the time hospitals aren't aware that this is a statutory duty to make housing referrals when somebody's identified as being homeless. So these teams, our pathway teams, actually helping hospitals to meet that statutory requirement and provide that clinically led housing support as well. So on the basis of that housing advocacy, we saw a 43% reduction in the number of people rough sleeping. That's comparing admission to discharge, a 21% reduction in the number of people who were sofa surfing, and a 62% increase in the number of people with temporary accommodation placements. We also see significant numbers of discharges which are facilitated to other appropriate care settings that might not otherwise have been accessed. So care homes, specialist supported accommodation, specialist and mainstream intermediate care, step down placement. So the team's really ensuring that patients are discharged to the appropriate location where they can have the appropriate support. And I think especially in the context of a housing system which is just under so much pressure, what we hear from our teams is that it's so hard to access temporary accommodation. These outcomes are really impressive in that very, very challenging context. Next slide, please, Paul. Some of the other key quality outcomes that we found from over the past year. So firstly, 85% of all patients receiving a holistic assessment and a comprehensive care plan. As Paul talked about, typically very complex needs, and what our teams do is not just treat the admitting problem, but really holistically assess all of those problems and develop a care plan to actually meet those needs. And this includes patients in A&E as well, so really impressive that our teams are actually delivering these assessments in A&E settings where there's often not that much time to work with patients. We saw that 97% of all patients were seen and assessed within 48 hours of referral, so really ensuring very timely access to specialist care and giving more time to plan effective discharges as well. We also saw, in general, we find that the patients seen by pathway teams, between 10 and 15% don't have a GP that they can access when they leave hospital, and this is obviously really important. So over the past year, we saw 255 patients supported to register with a new GP that they could access when they leave hospital, ensuring continuity of care, helping to facilitate their recovery and preventing the need for them to come back into hospital because they're accessing healthcare in the community. Next slide, please, Paul. So we can also take a look at some of the financial benefits of pathway teams. I think before I start to go into this, I just want to kind of say very strongly that the benefit of these teams is to the individuals, it is to the patients, improving their health, improving their housing, improving their quality of life, and helping them to ultimately end their homelessness or their other forms of social exclusion. So that's the kind of main impact. But we also do see that pathway teams can have quite a significant financial benefit for the hospitals in which they're located. And these financial benefits primarily come from reducing the need for people to reattend A&E or be readmitted to hospital. So what we find is that when you deliver a higher quality of care, holistic care, multidisciplinary working, and you plan effective discharges, things like reducing discharges to the street, obviously this helps people to recover and they're much less likely to need to come back into hospital as a result. And so we've done various cost calculations over the years, over the programme, and I'll just run through some of them quickly here. So firstly, we've done some costed case studies where we've taken individual patients who prior to being seen by the team had a high number of A&E attendances and a high number of admissions, and we compare a year period before being seen by the team and a year after, and we found avoided costs of between £6,500 and £17,500 for individual patients. So obviously if you scale that up to the number of people being seen over 1, 2, 3 years, there are significant avoided costs in terms of reattendances and readmissions as well. We've also worked with teams to conduct analyses of secondary care data from all of the patients seen by the teams, and we found very similar outcomes. After being seen by the team, there was a 66% reduction in the average number of A&E attendances per patient and a 61% reduction in the number of emergency admissions per patient. Again, that improved quality of care, helping people to recover out in the community rather than coming into hospital. And lastly, one of the other costs we can look at is the cost of bed days for people experiencing homelessness that are using hospitals. So a few studies of the Pathway model have shown around a 30% reduction in inpatient bed days used by cohorts of homeless patients who are accessing hospitals following new teams being introduced. So if we take the average number of inpatients seen by a Pathway team, which is 253 patients, and we look at the average length of stay of 8.3 days for an unplanned admission, multiply it by £901 per bed day, which is from the NHS cost directory, those patients could have incurred bed day costs of £1.9 million over a year. So if we apply that 30% reduction, we see that a single Pathway team could generate up to £570,000 in avoided bed day costs alone. So that doesn't take into account other avoided costs around A&E attendances, for example. So as I said, the patient impact, the human impact is the biggest benefit of these teams. Previous studies, we did an RCT of the Pathway model a while ago, and it showed that the teams are cost effective in terms of QALYs, but also the teams are realizing financial benefits for the hospitals in which they are based as well. So just to summarize all of those key data points, firstly, we're seeing a really high level of need for these services, and we're actually seeing that level of need increasing, more and more people being referred to the teams, a higher level of need for those services to exist. We're seeing some very impressive outcomes around improving housing status, delivering a very high quality of care, and connecting people into primary care services as well. And we're seeing that there are significant financial benefits of Pathway teams across the programme. Thank you. I'm going to hand over to Steve Cox now.
Yeah, good morning. Steve Cox. I work for NHS Devon, ICB. I work in the population health team, but for the past 3 years or so, I worked within the Plymouth commissioning team and worked very closely with Pathway in terms of the establishing the business case for our team, the implementation of the service, and then the ongoing support of the service. But in terms of a little bit about Plymouth, if you don't know it, it is has higher levels of deprivation than standard. It has higher levels of rough sleeping and higher levels of veterans, which is somewhat reflective of its history as a naval and a dock town. So the business case for our service was approved about 3 years ago, and Pathway were instrumental in helping us establish the business case and design the spec that informed that. So we have a team headed up by a GP alongside a mental health nurse, an OT, a social worker, a clinical psychologist, a support worker, and an administrator, and they work both in the community. So we have regular GP sessions at the 3 homelessness hostels that are in the city, and we're also based in the main hospital in Plymouth, which is UHP Derriford. Derriford has the unfortunate record of being one of the worst performing as defined by NHS England in terms of ambulance handover and wait times for ED. And I think that's much reflective of the growth in need and the inadequacy of the state rather than the commitment and will of the people there. But all of that is a cocktail that puts a great pressure on our service. We've been live for about 2.5 years. I should add we're quite unique that we also have a dentistry service, and although we haven't spoken about it as yet, oral health is a particular issue for those experiencing homelessness. So we've been running for 2.5 years. Pathway are very instrumental in the setup, joined our interview panels, supported us with project plans. So I've worked with Paul and with Theo and with Chris since that time, and obviously others in the team since then. But were an incredible help to get us up and get us started. To have that sort of expert opinion and expert knowledge on board certainly enabled the implementation and move at a pace. The need is great. Therefore, if you've got a business case and you've got a political will, you just want to get on with it. So the service has been set up, as I say, 2.5 years. It is not a panacea by any means, but what it has done is it has joined up what were in effect fragmented services across the system. There were GP sessions, there was a housing team in the hospital. But what our team has done is sort of brought a sort of unity to that. So in terms of results, I think I'll echo Theo's comments. It's not about reducing demand per se or reducing cost. It's about the humanity of doing the right thing and of treating someone with great need. And one of the challenges we had early on was around reporting and outcomes, and this whole sort of thing about reducing ED attendance, which is critical for a hospital that is struggling with the demand on ED. And the challenge that came back from one of the GPs was the 2 deaths that we've had this year in our hostel were 2 that should have gone to ED. But if you look at it purely through the crude statistic of non-attendance, they will be deemed as a success. So clearly one needs to be a lot more sophisticated in how one measures the impact of this service. But after 2 years in operation, we were asked to sort of look back at the business case that we constructed with Pathway and say, what have we done and how have we met the objectives of the original business case? And if we looked at some of the metrics, it was originally around reducing demand, or reducing rough sleeping, GP registration. All of those were exceeded and achieved. So the numbers tell the story, and it's a powerful case when we talk to, and we are a cash-strapped ICB as we all are, and even more so in coming months. So, but it is a powerful case that can be made for Pathway, and the support that we get from Pathway, it gives our service a legitimacy, a credibility that we are doing the right thing and that we are supported with experts in the field. Before we recontracted for the Pathway service, I asked the clinical lead, I said, what would your summary be of the support that we get from Pathway? And in his words, he said, the challenge for all of us, commissioners and providers, is that inclusion health is an emerging speciality. Without being part of a larger community, there's no governance, no sharing of best practice, and potential loss of resilience. So I think that alone is a testament to the value that we believe that we gain from Pathway. Hope that was okay, Chris.
Fantastic, thank you, Steve. Very kind of you to join us to say that about working with Pathway. I think it's very important, isn't it, to hear from somebody on the ground who's worked alongside us about what Pathway may bring and the sort of advantages that working alongside the established organisation bring to an area. So that I think that's all for the presentations. I hope we've covered the areas that we hope to cover, which were what's the problem we're trying to solve, how can we help you do that. Obviously important to have the lived experience voice from Gareth about what it means to people when better approaches are used than have been used previously, and then from Steve about working alongside us sort of in the practical terms, and from Theo about what the outputs and outcomes from the teams are. So if you want to keep in touch with us, please do keep in touch with us. If you've any ideas about ways that we could work together, if we've worked with you in the past and you want to pick that up, or if you think you'd like to have a needs assessment or a pathway team in your area, the contact details are there. If it's going to be soon, it's probably best to contact me, christopher.sargent@nhs.net, because Paul's going away on a well holiday for a couple of weeks. After that, you could contact either of us. And now we have time for some questions. So I think we're all happy to take any questions about the sections that we talked about, or anything that might have occurred to you around homelessness and health or inclusion health while we've been talking. Has everyone got access to the chat now? I think, because some people had a problem. We'll keep an eye on the chat and the Q&A and see what people want to ask us about.
If you raise your hands, we can also activate your camera and mic if you want as well.
Great.
To everyone. But...
Can't see. Can anybody see any questions yet?
Yeah, we have a question for Steve from Jane Quigley, asking IPP manager in Livewell Southwest, do Pathway in Plymouth support people leaving Glenbourne who are at risk of being discharged to homelessness?
The short answer is yes, they would support anyone within the Plymouth system.
So I think that question is probably asking, so in some areas, pathway teams just cover the hospital. And they may cover some hospital sites and not other hospital sites. So they may cover physical health hospital, or they may cover mental health hospital, or vice versa. But I think in Plymouth, it's all part of one system, isn't it? The PO1 system, so that they cover people coming from any sort of inpatient setting. Yeah.
There's a couple of more questions, Chris. Ruth Waitley in Bristol. What is the current situation with work in your legacy areas? E.g., I'm based in Bristol. Can follow up after if better. And there's another one after that, but.
Yeah, so I also work in one of the legacy teams down in Brighton. So with the legacy teams, we try to keep contact. We try to keep support. Obviously, we have people coming along to things like our masterclass events. So that helps to build a network. People are usually members of the Faculty of Homelessness and Inclusion Health, which is our membership organisation, which everyone is free to join. Have 3,000 people who are members of that. And then the various subgroups that Sophie touched on. So mental health subgroup, primary care subgroup, we have a student group, we have a system leaders and management group. Won't go through them all, but we have lots of subgroups where people with particular roles within inclusion health can meet and do that networking and get the support that Steve was talking about. Because equally, as people on the ground, sometimes people trying to get things going, at a commissioning level, can be kind of made to feel that this is a bit weird and a bit left field. So I think it gives people the reassurance that what they're doing is the right thing, and that they're backed by a big organisation with other people doing the same thing. So yeah, if anybody wants to join the faculty, please do feel free to join. So with the legacy teams, we try to maintain contact, we try to maintain support, and a lot of that comes through the faculty.
Right, we've got a few more questions. I could probably have a stab at this one. So Amy Robinson has asked, I wondered what mechanisms you are managing to use to resolve homelessness or secure temporary accommodation for vulnerable migrants. Are you able to use health needs to secure housing duties from local authorities? I think generally that's a big yes. So our teams are quite skilled at advocating for appropriate Care Act assessments for people with eligible needs especially when they've got no recourse to public funds. And beyond that, we would also look at any other routes into housing. So we might do home office routes like Section 4, Section 95 supports. There are voluntary sector organisations that can sometimes house people with no recourse to public funds. We also use reconnection services, specialist ones, but also where possible, our teams will also fund reconnection where it's safe and appropriate, obviously, as well. So yeah, a whole range, and obviously legal advocacy, helping people to resolve their immigration cases so that they become eligible for other services through local authorities is a big part of it where we can access that. Next question, we've got Steve Goldensmith, Buckinghamshire. Can you explain more regarding the interface with primary care where patients are registered, or the provision of primary care where they are not, etc.?
Yeah, sure, I'm happy to take this one. So our team model includes primary care, so usually a GP in the team, and that will be somebody who works locally in Inclusion Health. So in the situation in Brighton where I am, I'm linked into Arch, which is our primary care service for people experiencing homelessness. I also work in the hospital. So when a person is in the hospital, we check about their registration. If they're not registered with a GP, we register them with Arch while they're in the hospital, so that when it comes time to being discharged, they're already registered and they don't have to go through that process. We also have a multidisciplinary team meeting each week where we discuss the patients who are in the hospital, and that brings people in from primary care to talk about how the care of the person is going in the hospital. So it brings the primary care and community services around the person while they're still in, so that plans can be made for when they're discharged out. And I think that's a lot of where we get the benefit, is that we're not saying to somebody, you have to go from here, you're on your own, go and register the GP service, go and try and get your follow up in mental health, go down to the substance misuse service, all those things that people normally have to do when they're discharged from hospital, go to the housing department and sit and wait and make your case. We do all that for them while they're in hospital, make those connections and make kind of solid connections. We'll send somebody else with the person to go and do those things when they're discharged. So we'll send somebody with them to the housing department to pick up the keys and then get them to their emergency accommodation. And then we'll refer on to a service which can come and see the person and support them while they're in there. So a lot of that is sort of making those connections more solid and kind of sort of making a safety net for the person, rather than sort of telling them where to go and hoping that they'll be able to do it. Obviously, if you've just been in hospital for a while, you've been ill and you were street homeless when you came into hospital, it's quite a big ask to go to 4 different services on the day that you're discharged, and the chances are you're probably not going to make it to one or possibly all of those services. So providing a lot of extra support for the person when they're discharged and having set up those things while they're in the hospital does a lot to reduce those problems. There's a question about interpretation. Yes, so interpreters, so certainly in my team, and I believe in all the teams, we all have access to interpreting services, usually by the primary care route. So we have Sussex Language Line in my area, and we use that for people who don't have good English language skills.
There's another question, Chris, from Andrew Lloyd in the chat. Is there a cost to working with you? We have a range of provision in place already, but struggled with bringing our ICB commissioning together under a long-term funding approach to the activity.
Yeah, shall I take that one? Yes, there is a cost to working with us. So our Pathway Partnership Programme is £25,000 plus VAT per year. For the consultancy, we sort of negotiate depending on what people need in the local area, and a needs assessment usually comes in somewhere between 20,000 and 30,000, depending on what's needed and what areas are covered and the amount of work that it will be. So yes, yeah, we're a charity, but obviously we have to support ourselves financially. So so we do charge the areas that we work with. So Steve will be paying our partnership fee each year. Thank you, Steve. And all the teams in the partnership program will be paying a partnership fee to Pathway. Yeah. But if you've got ideas of how you'd like us to work with you, we're very happy to think about anything in the sort of inclusion health sphere. We're always open to new ideas. Any more questions? I'm trying to keep my eye on the chat and the Q&A. Looks like perhaps not.
We've
yeah,
got one more in the Q&A, Chris, from Melody. Okay. A more general question, concerned about the impact the proposed changes, reorganisation of the NHS and wider system will have on people experiencing homelessness / inclusion health groups, especially as there's hardly any money in the system. How do we continue to champion for inclusion health groups in a way that is effective, especially as these groups are also often forgotten?
That's probably one for all of us, I think, isn't it? I think in times like this, you keep going. We know what the solutions are. We have good evidence. We have nice guidance, and I think we all just have to keep shouting about it and make sure that people don't get forgotten. I think using the lived experience voice wherever we can and making sure that that's prioritised is one way to sort of bring home to the people who have the purse strings that these groups should not be forgotten about. I think there's the economic argument that doing nothing has a cost, and the doing nothing cost is higher than the doing something cost. So if you don't do anything, you will repeatedly have people experiencing homelessness coming in and out of the hospital, coming in and out of A&E at higher rates than the general population, which is what we know happens. If you do something about that, you can then help to reduce both the demand, both the misery that people are experiencing by having to do that, but also the cost of the services. So from my point of view, it's a kind of triple win, that everybody wins if you do something, but everybody loses if you don't do something. But I know that sometimes it's easier to try not to look over there and try not to do anything about that. I think the evidence from Steve is quite good too, that targets were set, all the targets were met, and the people going through that health system now are having a lot better experience in healthcare. So there are things we can do, and we have to keep shouting about it and keep trying. Don't know if anybody else wants to add into that.
Yeah, just to build on that, I mean, we talked a lot today about the national networks, the Faculty for Homeless and Inclusion Health, the masterclasses that all the teams can access, for example, and that network of specialist services. I think the value of these things is really that we know that it's so tough to drive changes for these groups, especially in the context of, as you say, being hardly any money in the system. So being a part of those networks, being engaged in those networks, sharing what's been effective in your area, people supporting each other. It can often be very isolating to work in inclusion health, sharing best practice, evidence, successes. I think being part of those networks is really essential in driving improvements in your local areas, but also across the country as well. So just encourage anyone who's not a faculty member to sign up for the faculty. I'll pop a link in the chat as well. But I think that's one of the key things that we can all do, is kind of come together, collectively share knowledge, collectively share experiences to keep pushing for changes we want to see.
Yeah, and I think we're sort of trying at all levels. We have a student group which is quite active and has just had their first Inclusion Health conference. That's growing, so we're trying to educate from the beginning. Alex has put something in the chat as well. Alex is our CEO, saying that we continue to advocate at a political level as well, at a government level. So all those representations are going on, and that's another part of the work of pathway as well, sort of the policy and programs. So we've produced policy papers for the new government about various aspects of inclusion health, which we hope will feed into their thinking. We're represented on lots of the sort of high level panels and advisory groups and things. So we try at all levels, but the ultimate aim is to try and improve things for individual people using individual services, and I think that takes effort from everybody in the system to do their bit to improve things.
I'd like Steve's take on this as well, because he touched on this, and also there was a question as well that says that a lot of this is already in place, but they all work individually. So therefore, the money's already there, but it's not working together. So what Pathways does is it brings all these teams together, and I think that's an important point. So I'd like to see what Steve has to say on that.
Yeah, I mean, I think the additional investment that we put into the Pathway service has joined things up. But just to give you an example, one of the things that the team is focused on is around safe discharge. There was a local authority commissioned housing team based in the hospital, and they could advocate for patients to not be discharged if they didn't feel that they were going to an appropriate setting, but they didn't have the medical clinical expertise to challenge doctors in the hospital who perhaps were not familiar with the challenges that setting may place. Now, having the Pathway team alongside them gives them that insight, gives them that support, which I think is absolutely vital. Similarly, there's an alcohol liaison nursing team in the hospital. They weren't linked up with any of this, so Pathway again has brought that together. So I wouldn't summarize it as I'd say it brings more than the sum of its parts. Really, you get more out of what is already there by having a Pathway team, and I think that is a really important point.
We've got a couple more questions in the Q&A, Chris. I don't know if you can see that, but I'll read out the first one.
Yep.
One I think Steve has definitely started to touch on already there. From Melody in North East London, a more general question. I am concerned about the impact of proposed changes / reorganisation of the NHS and wider system will have on people experiencing homelessness / inclusion health groups, especially as there's hardly any money in the system. How do we continue to champion for inclusion health groups in a way that is effective, especially as these groups are often forgotten?
I think we've done that all, Paul. So what's the next one?
Steve Goldensmith, inclusion health aren't necessarily homeless. For example, Gypsy, Roma, traveller communities. How do you work with those?
So the teams will work with anybody who's in an insecure housing situation who wants to work with us. So if people are perfectly happy with their situation, it's always done with consent. So if they don't want to work with us, but if we come across somebody who's been moving around, who now their health means that they can't move around anymore, then we work with them in exactly the same way as we work with any other form of homelessness. Similarly, with people who've not been homeless before but have found themselves homeless because of a health event, and all the wide range of homelessness groups. So the people who are self-surfing, the people who are insecure, the people who are threatened with homelessness, we'll work with all those people in the same way. So yeah, people who've been travelling in various different ways before, if that situation changes and that then means that they can't return to the situation they came from, we will work with those people in the same way to try and help them resolve that in a way that they were happy with. And in terms of our sort of general work, so that's the hospital team. In terms of our general work, then those groups would all be included in the work of the faculty, and yeah, they'll be included in our education work, our CPD day, in our conference. Those groups are all included in the inclusion health groups. Same with sex workers and vulnerable migrants. Any other questions coming through? No. Okay, so we might wrap up there a couple of minutes early. Thank you very, very much for joining us. Do stay in touch. As I say, my email address is there on the slide, and we'll be sending the slides out after this presentation. We're very happy to, have ideas and any new things that you think we might want to get involved in. Any way that we can help you to improve the health of the inclusion health groups, we're very happy to talk to you. So thank you for your time today. Enjoy the rest of the day. Thanks to all our speakers, especially Steve and Gareth, for joining us this morning. Thank you very much, and we'll be in touch with you soon. Thank you.